proceed to the next session, Type 1 Symposium. I would invite our chairpersons, Dr. Gaurav Bhaduri, Dr. Shukriya Datta, and Dr. Rahul Jain. If you could please come onto the dais for the next session. Our first speaker for this session is Dr. Vinay Dhandania, and the topic is early diagnosis and prevention strategies, screening for type 1 diabetes risk, genetic, immunological and environmental markers.
Dr. Vinay Dhandania for this session on type 1 diabetes, and he is going to talk about this. Slide. I'm not going to go for a detailed introduction because he's a very well-known figure in national bodies, and I have listened to him on various occasions. So the first topic for type 1 diabetes, please change the slide. So early diagnosis and prevention strategies, screening for type 1 diabetes risk, the genetic, environmental and immunological markers. So what do you say?
Thank you. Good afternoon. Thank you, madam, for that very kind introduction. I will request at the onset to give me 2 to 3 minutes extra for being a very big topic. I have to cover early diagnosis, prevention, screening, genetic, environmental, immunological markers, everything for type 1. So I may exceed 2 to 3 minutes. I'm extremely thankful to the organizer for this opportunity, and I tell you this is going to be one of the best presentations for this meeting, because type 1 diabetes is no less today in the community in our country, and as I proceed you will find that we have the highest number of type 1 diabetic children and adults in our country. So this is how it is we see today type 1 diabetics coming to your clinics very confident. The children are very, very confident and very cooperative and very compliant in their treatment today. So what is type 1 diabetes? Type 1 diabetes is a chronic condition with marked and progressive inability of the pancreas to secrete insulin because of cellular mediated autoimmune destruction of the pancreatic beta cells. And it's characterized by immune-mediated depletion of beta cells that results in lifelong dependence on exogenous insulin. Earlier, it used to be called by insulin-dependent diabetes mellitus or even juvenile onset diabetes, and it accounts for 5 to 10% of diabetes in the community. It's a growing health care problem. The prevalence in Caucasians is about 0.4%, and there is a marked geographical variance worldwide. Patients mostly present young, but may be diagnosed throughout life. We have an entity called as LADA, who actually presents later in their life. Globally, about 210,600 new cases of type 1 diabetes developed in the year 2000, and you can imagine the burden today. About 5.1 million persons will be affected by type 1 as mid of 2040, and about 61% of the prevalent cases reside in Europe and America combined, and both incidence and prevalence are increasing every year. You find a new data. In India, if you see, this is the second most common chronic disease in children, and it accounts for 5 to 10% of all diagnosed cases of diabetes mellitus, and incidence is 3 cases per year per 1 lakh IDF at the 6th edition, and of the 18 genomic intervals having the risk to develop type 1 diabetes, the major histocompatibility complex lesion on chromosome 6p21.31 has been the major contributor, estimated to account for 40 to 50%. Why I am sharing this is because this is going to be an important marker as far as prevention is concerned. India has the highest number of people less than 20 years of age living with type 1 diabetes among countries worldwide. Is the prevalence of the new cases as well as the old cases, existing cases. Incidence is relatively low compared to the Caucasians, Europe and US, but recent data, again the IDF Atlas suggests that we have the highest incidence of type 1 diabetes. Lifespan of our type 1 diabetes is unfortunately less. Government of West Bengal has established multiple juvenile diabetes centers recently, even in the periphery places like Malda, places like Purulia districts, and children are getting free health checkups, insulin supply and lab tests in all these regional setups. And I'm sure this is going to be moving at more and more and more countrywide. Type 1 diabetes is one of the commonest chronic diseases of childhood, and it peaks at around 5 to 7 years of age. The occurrence is slightly more common in men than in women. Seasonal synchronization suggests the role of environmental agents, especially during winters when there is more viral infections are more common. Viruses like Coxsackie viruses and mumps viruses, they have a direct impact. They can cause directly pancreatitis, viral pancreatitis, and initiate the process of type 1 diabetes as well. Is caused by autoimmune destruction of pancreatic beta cells triggered by environmental factors in genetically predisposed children, and responsible for approximately 70 to 90% of type 1 diabetes cases. Onset is fast and aggressive in children, and late onset autoimmune diabetes in adults is also common. Now, this is one interesting slide which suggests how the natural history of type 1 diabetes goes on. We have a precipitating events might occur in the utero. There is a genetic predisposition. The genetic predisposition probably the key driver to linkage to immune abnormalities like the precipitating factors, especially HLA, DR3, DR4. Then you have beyond precipitating and environmental might influence entire natural history. Then comes, although overall loss of beta cell is potentially linear, it could show a relapsing or remitting pattern, and that is why we often see a lot of children going into honeymoon phase after the intensive control of blood glucose initially. Then there can be presence of 2 or more island autoantibodies that might present asymptomatic type 1 diabetes, which can be at this particular stage, and this is where a lot of secondary prevention strategies has been implemented. Then there can be progressive loss of insulin release. Glucose can still be normal, but there could be a gradual decline in the insulin release, and later on there could be over diabetes. Less of C-peptide can be present later on, or even sometimes no C-peptide. But beta cell mass not only zero in long-standing diabetes patients. So type 1 diabetes is again a multifactorial disease like type 2 diabetes, and the product of environmental and gene interaction, viral infections, high-fat diet, beta cell maturation, genetic predisposition, toxins, prophylactic insulin. Cow's milk protein is again a concern in our country. A lot of ladies, instead of going for breastfeeding, start early cow's milk. There could be idiopathic variety of type 1 diabetes could be idiopathic, and cytokines are again a very big problem, and inflammatory markers. So this is how there is a development of type 1 diabetes, predisposing by genetic predisposition with HLA, DR3, DQ2, DR4 and DQ8. These are the major lymphocytic antigens. Then cellular T, autoantibodies like ICA, IAA, GAD, IA2. That causes insulinitis, beta cell injury, then loss of first phase of insulin release, pre-diabetes, and children will later on become diabetic. An environmental trigger initiates selective autoimmune destruction of the pancreatic beta cells in genetically predisposed individuals, and insulin secretion decreases as more beta cells are destroyed. So humoral autoantibodies in type 1 diabetes. Type 1 diabetes is associated with autoantibodies, ICA, IIA, GADA, and IA2A. Anti-GAD antibodies are the most sensitive. 90% of the Caucasians population with newly diagnosed type 1 have autoantibodies, and remaining 10% has no detectable islet cell antibodies, and they are termed as type B, type 1 diabetes type B, or idiopathic type 1D. So there are other type 1 diabetes inducing autoimmune process can also affect other organs, resulting in development of additional autoimmune disease. We know multiple autoimmune conditions, like they can have Graves' disease, they can have autoimmune Hashimoto thyroiditis, Addison's disease, vitiligo, celiac flu, and Hashimoto thyroiditis we see very commonly, autoimmune hepatitis, myasthenia gravis, and pernicious anemia. Again, genetic susceptibility, there can be good concordance rate of type 1 diabetes among monozygotic twins, and it's almost 30 to 70%. So I had one patient, Parul, who had a monozygotic twin, and that Parul, who was diagnosed diabetic at the age of 5, is still there. She is doing a genetic research at Dharmanga University. She married a type 1 diabetic, and she delivered a baby also. But unfortunately, her sister died because of some other reason a couple of yeers back, and she never developed diabetes. Over 85% of type 1 diabetes occurs in individuals with no previous first degree family history, but the risk among first degree relatives is 15 times higher. Why I am talking all these things is because they are the high risk people who can be put for secondary prevention. You should test them for antibodies, presence of antibodies. If they have one antibodies, the prevention is different, and they have multiple antibodies, they have to be aggressively put on preventive therapies. Association between type 1 diabetes and HLA genes, HLA DR3 and DR4 are more likely to develop type 1 diabetes. So this is how there is a risk progression, multiple insulin autoantibodies. The conversion is almost 44% at 5 years, 70% at 10 years, 84% in 15 years, and 100% in lifetime. But if you have a single antibodies, the conversion rate is less, 10% at 5 years and 15% at 10 years. So faster progression is seen with IE2 antibodies. So screening of autoantibodies in type 1 diabetes, insulin autoantibodies, glutamic acidic carboxylase 65 and 67 antibodies. These are also present in disease like Stiff-Man syndrome, which can be co-associated with type 1 diabetes. Protein tyrosine phosphatase islet antigen 2, IA2 or islet cell antigen, zinc transporter 8, zinc T8 antigen. Good predictive value for development of type 1 diabetes. Infants at high risk of type 1 diabetes based on HLA genotype or family history showed that early stage type 1 diabetes can be accurately identified by screening blood tests to measure major type 1 diabetes associated islet autoantibodies. So this is how the screening should be considered. Cost effectiveness should be considered. Optimal timing of screening should be considered. Most children who develop type 1 diabetes develop insulin autoantibodies at a younger age. However, antibody screening at only very young ages would yield negative results for the remainder of individuals that seroconvert later in life. So it should not be measured until the age is less than 6 months. It's very, very important because there you can measure the maternal antibodies instead of the actual antibodies present in the child. Counseling on the signs and symptoms of stage 3 type 1 diabetes. Stage 3 is basically the children have got multiple antibodies and they don't have symptoms of diabetes, over diabetes. So this is how we actually proceed. Single islet autoantibodies positive, annual autoantibody testing can be done. If there are more than 2 islet autoantibodies, because the seroconversion is very high, so you have to do HbA1c and OGTT. Many times they have pre-diabetes state if they have multiple autoantibodies. Stage 1, then you have to have annual monitoring of HbA1c and OGTT. Stage 2, you have to have abnormal glucose tolerance, semi-annual monitoring, that is every 6 months you can monitor them more frequently. So these are the recommendations for screening of complications and related conditions in pediatric type 1 diabetes, for thyroid disease, celiac disease, hypertension, dyslipidemia, nephropathy, retinopathy and neuropathy. There are a lot of biomarkers which are important. A biological biomarker is what is a measurable indicator that can tell us something about a person's health or disease state. For example, glucose levels that are used as a biomarker in managing diabetes. So similarly, we have a lot of biomarkers for even predicting type 1 diabetes in clinical trials. So improving the process of medicine development, clinical trials seek to measure patients' responses to a treatment, and if it is not possible to measure the response directly, biomarkers may provide an alternative way to measure it. So there are all of the different biomarkers we'll talk very fast. There could be antibodies as we have discussed. Then the important thing is autoantibody characteristic associated with increased risk of type 1 diabetes. So insulin autoantibodies, high risk in young children, GADA is associated with risk in older cohorts, IA2A is high risk in all ages, and zinc transporter 8A associated with risk in older cohorts. So again, if you have an antibody, you can predict the future onset of disease. This is the importance of biomarkers. The treatment dilemma is also very important here. How to go about it. The German BB-Diam and the Munich family study, they found that the follow-up of children with first degree family history of type 1 diabetes for the development of islet autoantibodies and type 1 diabetes, the serum samples were tested for the presence of all these antibodies, and the result was at diabetes onset, children who were followed after screening and were positive for islet autoantibodies had lower HbA1c HbA1c, lower prevalence of diabetic ketoacidosis, and shorter hospitalization rate. So this is the importance of screening. So screening for islet autoantibodies in children likely leads to earlier diabetes diagnosis, resulting in less complication and diagnosis. So this is what is very, very important to pick up high-risk children. However, no substantial benefit in the clinical outcomes during the first 5 years after diagnosis was observed. So development of diabetes in children is stratified for islet autoantibodies outcome. Again, the same thing presented in the graph. So the majority of the children at risk of type 1 diabetes on the measures of autoantibodies had multiple islet autoantibody seroconversion and progressed to diabetes over next 15 years. So if you have a child who has multiple autoantibodies on screening, you can actually predict that next 15 years is going to be type 1 diabetes. So these are the currently used potential biomarkers from serum for the diagnosis and prediction of type 1 diabetes: nucleic acids, proteins, and metabolites, exosomes. So these are done especially in research. They have been used more commonly than in clinical practice. Screening for other autoimmune disease is also very important, as we have discussed for thyroid disease and celiac disease is also important. HbA1c can be done, fructosamide can be done where HbA1c is contraindicated, glycated albumin can be done. Novel biomarkers are adiponectin. You will find that lower levels of adiponectin was observed even a decade before the development of diabetes. Fetuin A is another antibody, another biomarker which acts as an endogenous ligand for TLR4 for induction of insulin resistance by lipids. Therefore, serves as one of the novel marker in predicting future onset of diabetes. Metabolites and amino acids are hidden catalyzers. Alpha hydroxybutyrate can also be a biomarker. Lipoprotein A is again synthesized in liver. Triglycerides and high density lipoproteins are again studied in pre-diabetes. A significant increment in the levels of small HDL3 as compared to HDL-C levels have been observed. Ceramide is another biomarker. Ferritin and transferrin. So these are a lot of biomarkers under study as acylcarnitine, which can be one of the modalities for early diagnosis and prevention in the type 1 diabetes. Now prevention, I'll take two more minutes, sir. Prevention, we have primary prevention, secondary prevention and tertiary prevention. Primary prevention must be started very early in the life. First degree relatives, as we have read, we learned that the first degree relatives, if one is there, then the chances are almost 50 to 70%, and if the monozygotic twin, it could be almost to the tune of 70%. Genetic risk scoring is important. Avoidance of exposure to suspected environmental factors in high risk group due to potential role of infections in the pathogenesis of type 1, the opportunity to administer the vaccine. They have tried BCG vaccination as a modality of prevention in type 1 diabetes. The role of gut microbiome is another factor. Educate high-risk children, the high-risk family. Secondary prevention, especially for children with multiple autoantibodies, with or without evidence of beta cell dysfunction. There you can actually put them on screening from day one, continuous screening, and the only treatment available today, the FDA approval is for teplizumab, which is a monoclonal antibody infusion to delay the onset of symptomatic type 1 diabetes should be considered in selected individuals aged more than 8 years with stage 2 type 1 diabetes. Presence of HLA-DR4 and absence of HLA-DR3 were associated with more robust responses to teplizumab. Tertiary prevention is again very important. It allows us to avoid or delay the complication of diabetes. Many immunotherapeutic approaches are being studied and proposed to prevent type 1 diabetes. Vitamin D, high doses of nicotinamide have been tried. There are non-remedies also. Vaccines, oral and intranasal insulins has been tried. Immunomodulatory and immunosuppressive agents has been tried. Drugs like hydroxychloroquine and abatacept are also been tried. Stem cell therapy, dietary intervention, especially avoidance of cow milk early in the high-risk children is important. So I thank you all for your patient listening, and I thank the organizers for this opportunity.
Thank you, sir, for taking that extra time and finishing. So next we have Dr. Sanjay Bedi.
Very crisp and lovely lecture. Thank you. Always a pleasure listening to you, sir.
Speaker is Dr. Sanjay Bedi, talk on the management part, pharmacology and non-pharmacology.
Yeah, so the next speaker is Dr. Sanjeev Bedi. So he's a former administrative officer, Cardiothoracic and Neuroscience Center, GMCH. I hand over the session to Sir for his kind lecture.
Thank you, Chairperson. Thank you all the August gathering. Thank you, Dr. Patni, for inviting me and all the members of DRWA. So today my topic is type 1 diabetes, management, pharmacological and non-pharmacological. So it will be more of a practical approach how we treat type 1 diabetes. So the goals are to eliminate symptoms leading to hyperglycemia, reduce and delay complications, achieve a normal lifestyle, achieve normal physical growth and development, and prevent complications. These are the goals we take to in treating the type 1 patients, especially the children. So for this, we require a team approach in which a pediatrician, endocrinologist, nursing staff, dietitian, diabetic educator, and of course the social workers, each and everyone play a very important role in the overall development of the child throughout his journey with type 1 diabetes. So if you see the treatment of type 1 diabetes, it's only intensive insulin therapy. Type 1 diabetes, there is no other treatment, it's insulin, insulin, insulin. And we require to monitor the blood sugar frequently and insulin along with the dietary modification, exercise. Intensive insulin therapy has been shown to reduce complications by almost 60%. So insulin is the treatment of type 1 diabetes, and intensive treatment with insulin prevents complications by about 60%. And the goals of blood sugar varies from in the different age group. If you see the toddlers, that is 0 to 6 years, we are a little lenient and we keep the HbA1c around 8.5. In the school age, we are little relaxed, more around 8 we keep. And in the young adults and adolescents, we go in for stringent control. So in the toddlers and the young age group, our goals are different. We are lenient, but as the age progresses, we become more stricter in the control of HbA1c. And these are the various insulins which we use in the management of type 1 diabetes. Everyone must be knowing about it. The rapid acting, the short acting, intermediate, long acting, like Glargine and Deglutec. So analogs and the older insulins, everything can be used. And the regular insulins, we all know, converts from hexamer to monomers, so they require a time gap of around 30 minutes for the action to begin. As you can be seen over the slides over here, that it has got a broader peak. So the onset of action is slightly slower, and in between hypoglycemia can occur. But if you see the newer analogs like Lispro, Espartanol, the peaks are very thin and they are sharp edges. That means it starts early and finishes off early. So chances of inter-meal hypoglycemia and mainly nighttime hypoglycemia is less compared with the newer analogs, insulin like Aspartame, insulin Lispro. So this is the pharmacokinetic. You all must be knowing this chart. Nothing much to say. So in type 1 diabetes, it is the absence of insulin, which leads to the peripheral decrease in the peripheral utilization of glucose, leading to postprandial hyperglycemia. Also, the low plasma insulin causes increased glycogenolysis and gluconeogenesis, causing a rise in the fasting blood sugar. And to top it up, we have these counter-regulatory hormones, which also increases the blood sugar. So it is a lack of insulin plus the counter-regulatory hormone, which is the root cause for increased hyperglycemia in type 1 diabetes. So we use a mixture of intermediate or long-acting insulin and the short-acting insulin, one which covers the fasting state, the other which covers the postprandial state. So the insulin sites, we all know it, where to take the insulin, the site has to be rotated. The most preferred is the abdomen, followed by the outer arm, the thighs and the buttocks. The site needs to be rotated. You can't keep on giving in the same site because otherwise lipohypertrophy and lipoatrophy takes place as was highlighted in this slide. So the insulin requirement, it varies in the different stages of type 1 diabetes. If the person is in DK, as has already been discussed, the dose requirement is a little higher. In recovery also, the dose requirement is higher. But if you see the honeymoon phase and the normal intensification phase, usually the dose stays from 0.7 to 1 unit per kg per day. But during puberty, because the hormones are very high in the pubertal stage, so during puberty the insulin requirement increases to almost 1 to 1.5. That has to be kept in mind. And the insulin, the site where the insulin needs to be injected has been highlighted. It needs to be injected in the subcutaneous tissue. So the honeymoon phase, we all know that some amount of beta cells are initially left. So some amount of endogenous insulin is secreted, and so the requirement of this exogenous insulin is less. So in the honeymoon phase, almost 50 to 70% drop in the insulin requirement is there, but this stage lasts for about 1 year, and after that the insulin requirement will be again increased. So diabetes in toddler, it's a very, I have just put one slide over here because it's a very interesting to note that in toddlers they behave in a different way. The hypoglycemia is common and they manifest as pain, cranky, sweating, they give a peculiar cry and there can be bluish tinge of lips and finger. Also tempered tantrum can be there as the chief symptom of hypoglycemia. The main thing in toddlers is that we need to be lenient. The blood sugar should be around 200. Otherwise, and the HbA1c around 8.5, because if there is repeated hypoglycemia, then there can be permanent cognitive, intellectual and learning defects. This on the MRI manifests as mesial temporal sclerosis. So hypoglycemia is more worse in the toddler than hyperglycemia, and we need to prevent hypoglycemia if we really need a good intellectual development of the child. The insulin regimen which we use is 2 dose, and that is a split mix and the basal bolus, we all know it. The 2 dose, this occurs gathering must be knowing about it, but I'm just highlighting. We give the 2 dose insulin based on 2/3 of dose in the morning and 1/3 in the evening. Of this 2/3 is NPH and 1/3 is short acting. And in the evening also 2/3 is NPH and 1/3 is short acting insulin. So this is how a typical 2 dose split mix regimen occurs, looks. But the 2 dose is not the ideal dose for a type 1 diabetic, because peaking in the blood sugar following lunch is not covered by the morning sort of short-acting insulin. So after lunch, this hyperglycemia is there, and the patient needs to be given an extra dose of short-acting insulin if you really need to overcome that hyperglycemia. Again, the peak action of morning NPH falls between the lunch and dinner, so late evening hypoglycemia can occur, so a snacks needs to be given. Also, NPH insulin during the peaks during the night, giving rise to nighttime hypoglycemia. So NPH insulin is not sufficient to prevent the rise of hyperglycemia before breakfast. So these are the shortcomings of split mix. First of all, the morning there can be the hyperglycemia following lunch. There can be hypoglycemia following in the evening. There can be late evening. There can be late night hypoglycemia and early morning hyperglycemia. So because the insulin profile is such, we are not able to give a 24-hour blood sugar control. But if you see, and to overcome this, we need to give the patient 3 meals and 2 to 3 snacks in regular interval. But the basal bolus is more physiological because it acts in a more physiological manner and it provides 24-hour coverage throughout the day with a basal insulin and the prandial insulins without definite peak and a flatter action. Given we all know that the advantage of postprandial blood sugar is better control with this basal bolus regimen, and this early morning hyperglycemia and after meal hypoglycemia is also taken well care of by the basal bolus. So basal bolus is the more physiological form of delivery, but it comes with a disadvantage of more number of pricks. So this is how the basal bolus looks, and this mimics more or less the normal physiological insulin. So the subcutaneous dose of insulin varies from age to age, from 0 to 5. These are the target blood sugar has been shown from 100 to 200, 5 to 12, which is 80 to 150. But the dose requirement also varies, 0.6 to 0.7, 0.7 to 1, and as I've told in puberty, about 1 to 1.5. So the total, the weight of the patient divided by the amount of dose of insulin needs to be given, and then you can split it 50% this basal, and the rest 50% is bolus. Also, we need to have this carbohydrate counting, especially in the children, because it is the method of calculating the amount of carbohydrate consumed at meal and snacks. It is not specific diet, but a meal planning approach to promote glycemic control. So, how do we do the carbohydrate counting? Here we follow the rule of 500, in which we divide the total daily dose of insulin in 24 hours. We divide 500 by the total this daily dose of insulin. Suppose the child is taking 1 unit per kg per day in 24 hours. His weight is 20 kg. So 500 divided by, that comes to 20 units per day. So 500 divided by 20 is 25 grams. So 1 unit of insulin will cover 25 grams of carbohydrate. But here also in the younger age group, it has been seen that 20 to 30% is covered by 1 unit of insulin. In the older age group, it drops to 10 to 15. And in the adolescents, 1 unit covers 25 grams. So carbohydrate counting is very important. If you can teach the child how to go in for carbohydrate counting, then we can cover the postprandial hyperglycemia according
to his or her carbohydrate load. Also, the carbohydrate content can be seen from the food. Nowadays, the processed food has got a label. You can just see the label over there. And here, only thing to be highlighted is sugar alcohol. Sugar alcohol need not be taken as full. If it is sugar alcohol is there, it is completely inabsorbed. Hence, half of the sugar is taken into consideration. Same, if there is dietary fibers needs to be substituted from the total carbohydrate. So, from the processed food level also, we can see the amount of carbohydrate. So if the child is unable to administer 4 injections daily, then we can compromise with 3 injections. We can give NPH or bolus in the breakfast, short-acting insulin at supper, and NPH at bedtime. And of course, the 2 injection regime, but it comes with the disadvantage of hyper and hypoglycemia. So the goal is to achieve a near blood sugar at all time with minimal hypoglycemia, thus delaying long-term complications of diabetes. So we need to monitor the blood sugar constantly, because for split mix, the 4 times a day, that is pre-breakfast, 2 hours after breakfast, pre-dinner, and 2 hours after dinner is what we do in case of split mix regime. In case of basal bolus, we see the fasting, the post-meal, before lunch, after lunch, before dinner, after dinner, 3 a.m. sugar. We all know. So the adjustment accordingly, if the fasting sugar is high, the night NPH needs to be adjusted. If the pre-lunch is high, the morning regular. If the pre-dinner is high, the morning NPH. If the bedtime insulin is high, night-time regular insulin needs to be adjusted. In case of basal bolus, it is if the fasting and pre-meal are high, long-acting analog needs to be adjusted. If the post-meal is high, then of course the pre-meal regular insulin needs to be adjusted. We know the dawn and the synovial effect. The dawn effects occur because of increased secretion of growth hormone. There is early morning hyperglycemia, and here we can just tackle it by reducing or by adjusting the dose of NPH at night. Whereas in synovial effect, it is because of the counter-regulatory hormones which are secreted at night, giving us to early morning hyperglycemia. Here we need to reduce the dose of NPH at night. So in one we adjust the dose, in other we reduce the dose. Also, exercise and physical activity needs to be done. The carbohydrate intake and reduced insulin dose are very important to be monitored. The exercise, during exercise, 30 minutes of moderate exercise, about 15 grams of carbohydrate needs to be intake, and blood sugar above 250 person should not go in for exercise. Also, the school health authority needs to be made equal partner in the treatment of type 1 patients, because the child may have hypoglycemia in the school, and how to overcome this hypoglycemia, it is what the school authorities need to be educated. Hypoglycemia I will not state because the previous talk speaker has dealt on this. So for energy requirement, we require the age, the sex, the physical activity, and the body weight. They all matters if we really need to calculate the energy requirement. In a diabetic diet is a very big chapter, but I will just highlight few slides. This is just in the diabetic diet, the carbohydrate should constitute about 55%, the protein should about 15 to 20%, fat should constitute 30%, but if the child is obese, we can bring it down to 20% also. So this is a typical diabetic plate, in which half of the plate is vegetables, 1/4 is grain and starch, other is the meat and the protein which we give, plus milk and fruits, of course, are there. So, what are carbohydrates? We all know, a very important part. These are the food materials which contain carbohydrates. These are the foods which have little or no carbohydrates, mainly non-starch vegetables, fats, proteins. Carrot counting, as I have already told you before. So, this is the one serving how much of carbohydrate and carbohydrate is there in a particular meal. Like an apple is 15 grams, brown rice 1/3 cup is 15 grams, milk 1 cup is 12 grams. So we must know all this chart in the house for the type 1 diabetic patients, so that they can see the carbohydrate counting and take their meal accordingly, and also to overcome the hyperglycemia or to do rescue hyperglycemia which is there. They must go in for carbohydrate counting. So the basic tool is the rule of palm, in which we take the thumb as the, say, cheese, one piece of cheese, as the thumb size of the thumb should be of the cheese. The size of the tennis ball should be of the carbohydrate or the rice. The size of a golf should be the peanut butter and all which the child loves. And of course the palm, the main part of the palm is the amount of protein. So this is a nutshell how we should go in, how we should teach the patient how to take the basic control of protein, carbohydrates and fats. So thank you everyone. Thank you for your patient hearing. Thank you again Dr. Patni and the entire team for giving me this opportunity of sharing this experience with you. Thank you.
Thank you, Dr. Sanjeev Mehdi, for your wonderful presentation. So, our last speaker for this session of type 1 diabetes is none other than Dr. Dwra. And I would never, go to introduce him. He is very much well known to all and is one of the excellent endocrinologists. So, topic is prevention of complications from type 1.
Thank you very much. I'll try to be on time. Okay. So to start with, my job was cut out by Dr. Patni because, as Dr. Mehdi said, treatment of type 1 diabetes is insulin. How do you prevent complications of type 1 diabetes? Insulin. So that's the easy part. Had it been type 2 diabetes, I think we'd have discussed a lot about SGLT2, GLP-1 and many other molecules. And I have stopped using Google. I use Grok a lot. I was discussing with my friend Harish here. This is the one I prepared with Grok. And you just feed in the article you want and they prepare the slides for you. So this is the complication spectrum on an annualized basis per 100 patients in patients with type 1 diabetes. So the acute hypoglycemia or hyperglycemia complications are the major burden of complications in type 1 diabetes, which was discussed at length, I think, before I took the podium, followed by microvascular and followed by macrovascular. Always remember that these are annualized. And so once a type 1 diabetic becomes more than 15 years or start accumulating more than 2 additional risk factors, then this graph will look completely different. It won't look the way it is looking. So acute complications have been discussed in length. I just brushed through them. You need to remember that severe hypoglycemia has its consequences, but severe hypoglycemia also prevents you from achieving those glycemic targets, which are extremely important in type 1 diabetes compared to type 2. You can get away with a mild glucose control in type 2 diabetic because of the additional cardioprotective drugs or nephroprotective drugs. Not here. We absolutely need this. And remember that the incidence of severe hypoglycemia is dependent mostly on the duration of diabetes and not on the age of the patient. These are the different consequences of severe hypoglycemia. We know all about them. As a matter of fact, the infamous term death in the bed syndrome was coined after the death happened in a patient with type 1 diabetes. It's come from there. Scaremongering about hypoglycemia in type 2 diabetes happened taking the type 1 diabetic example into focus. So we need to remember that. Now, how do we then reduce it? You have analog insulin, you have U300, you have degludec and all others. Remember, they are overpriced as far as management of type 2 diabetes is concerned. Still, a very simple human insulin, very simple U100 large is good enough. But the value addition comes when we use them in type 1 because they definitely reduces glycemic variability as well as the risk of hypoglycemia. But for those in whom we are experiencing hypoglycemia as an impediment to achieving good glycemic control, CSI is a good option. Those who can afford, then the insulin pump therapy is a good option. But remember that is not a panacea. We still have a significant amount of our patients who will experience hypoglycemia even while on CSI. So we can have the closed loop system, and where the low glucose suspend feature is there. Wherever the glucose is going down, the machine shuts off. So you can have that closed loop system which can cut down hypoglycemia even more. Or you can have the bionic pancreas where it's no longer insulin, but insulin and glucagon are both playing together in order to take care of hyper and hypoglycemia. So these are advanced models which can help you to take care. Now DKA again is the other acute hyperglycemic complication in type 1 diabetes. See, the mortality is pretty high, especially in the younger age group. So DKA related problems we should be extremely aware in those in the younger age group compared to those who have been type 1 diabetic for a pretty long time. And it is directly proportional to your increasing HbA1c. And as again, we are coming back to the point, A1C control is extremely important in our type 1 diabetic population. We need to monitor ketones during illness. We need more active monitoring, either through SMBG or through CGMS, apart from detecting hypoglycemia. So those 6 days rules are extremely important in preventing DKA. I was discussing with Harish our common problem. A young lady, or a young girl diagnosed with type 1 at the age of 5-6 years while in, or 7-8 years in school, and post, marriage and thing, 10-15-20 years down the line becomes obese. Now, a lot of them do not maintain their paper antibodies, positive results, and they are then sometimes thought of as type 1 and put on medications. I have a couple of patients ending up with DKA when they were taken off insulin, so we need to be extremely careful of such mishaps. Microvascular complication, a small quiz. The fasting glucose value of 126 cutoff came from which complication of diabetes? Is it cardiovascular? Is it nephropathy? Is it retinopathy? So the cutoff has come from retinopathy. So the best way of reducing retinopathy, whether it is type 1 or type 2, is through good control of your blood glucose. And DCCT has taught us a lot of things. The metabolic memory is discussed at length in type 2 diabetes, but it actually is come from DCCT. It's come from the type 1 diabetes study. Now this is the ADA 2025 recommendations. It's not only good about knowing about complications, but how to prevent them. So we need to screen our patients annually at least. You can wait for 5 years. First 5 years is a honeymoon period for most of our type 1 diabetic population. Then the screening starts just like in type 2 diabetic patients. Annual screening for retinopathy, annual screening for albuminuria. They are extremely important. And treatment is safe. Once they develop the albuminuria, especially significant albuminuria, RAS blockade is an extremely important part of the treatment, especially if they have hypertension. Macrovascular complication, again you see the mortality is pretty high in patients with type 1 diabetic, and cardiovascular mortality is extremely high, and we do not have an SGLT2 or GLP-1 to fall back upon. So glucose control cannot be compromised in our patients with type 1 diabetes. Especially if the type 1 diabetic patient develops proteinuria, then these patients are at extremely high risk of developing cardiovascular mortality and all-cause mortality. As a matter of fact, all-cause death is near about 40-fold higher in such patients. So we cannot just discount of the fact that they are type 1 diabetic and we start treating them differently from type 2. The risk factors are quite acute, and again I come back to the point, we do not have disease-modifying drugs to fall back upon, so let's be extremely prudent and control the diabetes and achieve the diabetic target. Now again, since we do not have disease-modifying drug, we need to control their blood pressure, we control their lipids apart from their blood sugar. So these are the recommendations for hypertension screening. There should be screening at every routine visits. We need to use the age cutoff, the drug. For example, we need to put someone on a statin. The only recommended statin up to 6 years of age is rosuvastatin. So we need to find out which statin is for which beta blocker or calcium channel blocker is approved for which age group. So we need to be extremely careful of that. Dyslipidemia screening, initial screening should be performed soon after diagnosis, or wait, let glycemia improves and then do the screening, because while there is an acute hyperglycemia, you can have an erroneous result. So we need to wait for the sugar to be controlled and then do the lipid screening. And again, age-approved statin, LDL targets the same as less than 100, like in type 2 diabetic population. Let's not forget, complication is not about acute complications and macrovascular. There are two autoimmune-related complications associated with type 1 diabetes. Rule out thyroid dysfunction and celiac disease. Especially someone who is diagnosed in the youth with type 1 diabetes, you need to get a TTG antibody done, and then you can again repeat it if the patient has symptoms, or 5 years later if the patient doesn't have symptoms. Thyroid disease soon after diagnosis, and if it is normal, we can do it every 1 to 2 years as required. So to summarize, the picture would have been quite different. This pyramid would have been quite different if I had been probably discussing type 2 diabetes. In type 1, early diagnosis is extremely important. Nowadays we have got therapies which can be instituted even before you develop type 1 diabetes to prevent them. So early diagnosis and suspicion is extremely important. Glycemic control is the bedrock of management and of prevention of complications of both acute, macro and microvascular. Yes, CGM is an important tool, but those who can't afford or where there are problematic areas, a 9-point or a 7-point SMBG does an equally good job, but they have to be utilized, because without monitoring, the treatment is not that effective. Annual examination of eye, annual examination of the urine for protein, annual examination for blood pressure on every visit, and annual for the lipid profile after 5 years have elapsed from diagnosis, and so that needs to be remembered. DCCT ethics still remains, I think, the cornerstone of the trial, based on which we have learned so much about type 1 diabetic. It's extremely important to know about diabetic education. For those who have been in UK, they know the importance of DSME, they know the importance of Desmond and Diamond for type 1 and type 2, and reinforcement of the education that every 6 weeks to 6 months interval, a single education program doesn't make sense. We need to educate our patients on periodic interval. So I think with that I'll end. I have 75 minutes, ma'am.
Thank you, Dr. Samit, for wonderful presentation as usual and finishing way before time. So, any questions from the audience?
I'm Dr. Ipungarasa. I do have two questions, in fact. One simple confusion to Dr. Dandania, because you say the ferritin E is the biomarker of type 1 diabetes. So for our knowledge is concerned, it is a type secreted by hepatocyte, and it enriched the downstream signal of insulin. So that's more related to insulin resistance. Number one. Number two, all the speakers, when you suspect that type 1 diabetes is developing some sort of insulin resistance or the so-called hybrid diabetes, what are the biomarkers or clinical settings we can at least understand if a particular patient might go into the hybrid diabetes? Thank you so much.
I think Dr. Meghi made a very clear statement. During puberty, the insulin requirement is increased. Yeah. And that is one of the reasons, because of increase in pubertal hormones, that causes more of insulin resistance, and that is how you require more of insulin. But that doesn't mean you put them on oral drugs to take care of their insulin resistance. That is not been recommended.
I think even in the long term, when your patients require a large volume of insulin to maintain their HbA1c, they behave like a double diabetes. They start bloating up. And hence SGLT2 and GLP-1 have been tried. SGLT2, surprisingly, I think Astra has withdrawn their indication. So it's no longer there. GLP-1 is again being tried and is recommended big time in those subset of patients. So maybe you can give a trial of GLP-1.
In those cases where there is an entity called as Moriarty syndrome, I will tell you. There is an entity called as Moriarty syndrome. Moriarty syndrome is seen in children who have been over-insulinized and they put on weight, they have fatty liver, they have high triglycerides, but they are type 1 diabetics. So you need to take care of their diet, and you need to put them on exercise and reduce the dose of insulin accordingly. And what is Moriarty syndrome?
In those class of patients where they manifest some features of insulin resistance also, GLP and all, they do a very wonderful job, because many of our patients, they don't behave like type 1 typically, they don't behave like a mixture of type 1 and type 2, type 3 diabetes we say. In those class of patients, apart from insulin, after giving insulin, insulin is to be given. Insulin can't be substituted by any other medications. After insulin, you can give a dose of GLP-1 if you come across, and then also it has been monitored and all.
Yes, all the GLP studies just showed that it helps you to cut down the dose of insulin, nothing else. So if you cut down the insulin-related anabolic effects can be cut down.
But insulin is the treatment of type 1, nothing, there should be no ambiguity on it.
In our clinical practice, it is a common phenomenon, it's a binge eating. Fear of hypoglycemia, taking foods over and over again, and you develop obesity. That is one factor in clinical practice.
So lifestyle modification is very important.
Very important.
More so.
So I think the second that ferritin A, if it is positive in type 1 diabetes, that might indicate that the patient might go into a double diabetes.
So in type 1, I think in those patients who are experiencing frequent severe hypoglycemic episodes, the ADA tells you can relax the A1C up to 8.
Yeah.
So that recommendation is there.
In fact, in children, 8.5 is the ideal HbA1c which you should plan. If you can get that also, that is very good. Thank you.
So what do you do, Harish, in your obese patient? Harish, what do you do? Obese type 1. Lifestyle.
Lifestyle modification is very important.
Have you tried GLP-1?
I haven't tried. Excellent talk by all the three speakers. And Dr. Sharma, now that we classify type 1 diabetes based on the stages also, so is there any preventing action to be taken? Now that once they have developed disease, there is a treatment. So any preventive action to be taken in stage 1 and stage 2? And so what do you do?
I'm not aware about, see, type 2, you have a lot of indicators that you have a family history and then you're becoming obese and you need to cut down to annualized checkup to see whether you're pre-diabetes. Type 1, we still have a big question mark. Is it the bovine milk or is it the virus or is it the maternal nutrition? We still don't know the exact trigger. So the preventing part, I'm not very sure. Because they're saying that if you have not yet developed type 1, you can put on immunotherapy to prevent it. But what exactly are those signs?
That's exactly
The same old BCG has been shown to have some preventive aspects. So some results are there.
Very small studies. I shared few data regarding some immunomodulatory therapies and monoclonal antibodies which can be used in secondary prevention, not in primary prevention. Primary prevention, as I said, you don't have much to do except to evaluate high-risk individuals. High-risk who, like, I have a family member who is a type 1 diabetes and I am one of the same thing. So my risk is higher than someone who is not having anyone in the family. So someone who is not having anyone in the family has a risk of 0.4 to 5%, like we have the data. But someone having one member in the family has got almost 15%. The percentage increases to 15%. And if I have one antibody positive being 15%, and if I have multiple antibodies being 15%, makes a lot of difference. If I have one antibody, my risk is less of seroconversion. But if I have multiple antibodies, my seroconversion rate is very high. Now here we don't have data as far as primary prevention is concerned to put them on immunomodulatory therapy. But it's very important that you put them on things like prevent environmental triggers which can be actually taken care of by vaccination. Simple flu shots, like in our country, even flu shots are not being given annually to high-risk individuals. Even our diabetic patients, I don't know how many of us are using flu shots to all our diabetic patients. Even annual flu shots can be useful to them. BCG vaccinations, there are few data, but it's not been validated today. So all these things can be tried in primary prevention, but important thing is follow-up. You need to educate them. I was happy to see DSMEs being spoken here. Diabetes self-management education and support is the key in prevention of or even delaying the progression of antibody insult to the beta cells.
So Harish, we were discussing like the two spectrum of type 1, autoimmune disease related and non-autoimmune.
Yes.
So you can have type 1 also. So the entire therapy, immunotherapy for prevention of type 1 diabetes is based on those who are the autoimmune risk, not the other one. For them, the studies which were done looked at the newborns and their 98th percentile growth was looked into and their failure to thrive was were indicators for testing for autoantibody. So if you get hold of them, they have not yet developed hyperglycemia but have the autoantibody positives. They are the ideal candidates for prevention with the immune therapies. Monitors. So the thrive and the age, the 90th percentile, I think is going to be extremely important.
Thank you so much all the esteemed speakers and chairpersons for that excellent Type 1 symposium.